I'll call this meeting to order, and without objection, the chair is authorized to declare recess at any time. Good morning and welcome to this Science, Space, and Technology Committee for the 117th Congress. It is fitting that our first hearing focus on the COVID pandemic and the role of vaccination in fighting this virus and its devastating impacts. As the first nurse elected to Congress, I'm deeply committed to understanding how basic research supports healthcare solutions, and I'm also a firm believer in vaccines. We must build high public confidence in these vaccines. We simply cannot and will not bring this virus to an end unless we vaccinate a high percentage of the American population, and in fact, the globe. I hope our hearing today will help illuminate the methods that allow these vaccines to be developed and approved quickly with scientific rigor, and that we will learn more about how vaccine hesitancy might threaten the pace of our national recovery.
Thank you, and good afternoon, Madam Chair, Ranking Member Lucas, and members of the committee. I'm Allison Bottenheim. I'm an Associate Professor of Nursing and Health Policy at the University of Pennsylvania School of Nursing, and I'm a behavioral scientist who studies vaccine acceptance and vaccine hesitancy. As Chairwoman Johnson mentioned, I had the honor of serving last year on the National Academies Committee on the equitable allocation of the COVID-19 vaccine. And as part of that effort, recently co-authored another National Academies report entitled Strategies for Building Confidence in the COVID-19 Vaccines, on which my written testimony was based. That report is chock full of very specific communication and engagement strategies to address hesitancy and ensure demand for our truly amazing COVID vaccines. And we hope it'll be a helpful guide to public health agencies at all levels working on vaccine rollout. In my very brief time with you today, I'd like to expand on that report and share some additional insights and evidence that can further guide us as we tackle the last mile challenge of getting shots in arms. Here are 5 science-based solutions that I hope Congress can endorse, fund, and promote. Number 1, embrace the dual goal of vaccinating efficiently and equitably. This recently has been framed as sort of a false choice or an either or, with people saying that we can either be fast or be fair with vaccine rollout. We have the science to do both, but we have to be deliberate, intentional, and innovative in our approach to both tracking and achieving those complementary goals. Number 2, fix the easy stuff. Hesitancy is definitely a barrier to vaccination, and I look forward to talking about that, but so are hassle factors. Even people who are motivated and excited about the vaccine can be deterred by the smallest amount of friction in the system, whether that's complex logistics, inconvenience, or confusing instructions. Making and keeping a vaccination appointment should be easy and hassle-free, and frankly, fixing those hassle factors is often easier than changing someone's mind. Number 3, keep doing the hard stuff, even if it doesn't scale. There are a lot of people with very legitimate concerns about the speed of vaccine development, diversity of trial participants, or trust in the medical research establishment. What's emerging as the most effective way to help those folks is sustained, repeated one-on-one conversations with trusted peers or vaccine validators. Now, you can't bake that kind of engagement into a chatbot or a website FAQ or a message on the side of a bus or even a TikTok video. We have to stand up and support those time-intensive interventions and get them to the people who need them, even if they don't scale. Number 4, use fun and delight. As Cass Sunstein has said, there's a deep human need to smile and laugh, and we can leverage that need through evidence-based messaging and promotions that exceeds people's expectations about the vaccine and about getting vaccinated in surprising ways. One example that I hope you've all seen is the Sleeves Up NOLA public service announcement from New Orleans.
It's my shot.
It's my shot.
It's my shot.
It's my shot.
Es mi vacuna.
It is my shot.
I'm getting the vaccine because in the Jewish faith, preserving life is the most important religious act.
So we can continue to deliver the message to the churches in the community.
To protect myself and those who come to my congregation.
And I certainly don't want to give it to anyone else.
Sleeves up, NOLA.
Sleeves up, NOLA.
Sleeves up, NOLA.
Sleeves up, NOLA.
Súbete la manga, Nueva Orleans.
It's a truly fantastic example of that idea of leveraging fun and delight. Lastly, number 5, fail fast, learn fast. Behavioral science advances in much the same way that lab science does. We generate hypotheses about an effective intervention, and then we test those hypotheses via experiments. We need to bring the same speed and rigor to vaccine acceptance research that we brought to vaccine development research, so we can get it right in real time and also learn for next time, because this is not our last rodeo. Both immediate and long-term investments in behavioral science research are needed. So to recap, we can be fast and fair. We should address hassle barriers to vaccination in addition to hesitancy barriers. Some of our most effective strategies won't scale, and that's okay. Fun is effective, and learning what works is critical. I want to thank the committee for your time today and for your commitment to a science-driven vaccine rollout.
Dr. Nuzzel and Dr. Bottenheim, Mr. Reed referenced a recent survey in Oklahoma that 33% of my fellow Oklahomans do not plan to get the COVID-19 vaccine. And they cite lack of information on the vaccine, concern about development, safety, all those sort of things. What can we tell our constituents back home to emphasize the safety of the vaccines authorized for use? Yes, you're writing my town meeting speech for me here.
I mean, I can say from a communication standpoint, luckily we have the amazing data that Dr. Nuzzel and her colleagues have generated from these trials. One thing that I think is important is that people need to hear it more than once, and they need to hear it from trusted communicators. That might be clergy, that might be local government leadership, that might be other family members who are doing the online research for them. But the main, the survey data that says the main concerns are the speed of the vaccine development. Dr. Nuzzel just walked through that in an amazing way. That it wasn't tested on people who look like me. We actually had quite robust diversity in the trials, and we don't know the long-term side effects. We're starting to accumulate that data, and we have incredible safety profiles. So I think it's sort of hitting those 3 again and again and again, but making sure if people have another set of concerns that we hear those and address them as well.
And it seems like there is so much to learn from our experience with this pandemic. We need to better understand everything from the origins of the viruses and the development of the therapies and vaccines to the pandemic preparedness and collaborations between federal, state, and local governments and public health officials. After 9/11, Congress appointed a commission to cut through the politics of finger pointing and focus on the facts. Last week, I introduced legislation to do the same thing for COVID. Do you think, each of you, that we could benefit from such a commission?
Hopefully, we can also learn from some of the behavioral and policy interventions. How did we do at getting people to mask? How did different kinds of lockdowns and stay-at-home orders work? And use the 50 states and local jurisdictions as sort of case studies to see what was effective.
Dr. Bottenheim, Johnson & Johnson, as we know, has applied for their emergency use authorization for its vaccine, and that application will be considered soon by the FDA's Independent Science Advisory Board. So having more vaccines is clearly a good thing, but people may be understandably hesitant if offered an option that is found to be somewhat less effective than Moderna or Pfizer at preventing mild and severe infection. And so the difference in these efficacy results received a great deal of media attention, but it's my understanding there have been 0 cases of hospitalization or death in clinical trials for all 3 of these vaccines, including Johnson & Johnson. So with the questions that are arising about the differences between the vaccines, how can we most effectively address the concerns with the public and really communicate complete and accurate information? If we're using Johnson & Johnson, for example, in rural areas or with transient migrant populations, there's going to be equity issues there. Why are we giving those populations something that is less or looks to be less effective? So could you discuss that, please?
Yeah, this is going to be a challenge. And I think as we think about the sort of choice architecture, how we arrange environments for people to make choices, one thing we don't want the average American doing is choosing their vaccine. This should be sort of your provider or this clinic is off or this state is using this vaccine in their program, and lucky you get it. Those sort of extra choices that cause kind of cognitive load do not have a place here. And yet we have the sort of wonderful problem that we've all anchored on the incredible effectiveness effectiveness of Pfizer and Moderna. So something from J&J that looks maybe a tiny little bit less effective, but is still a great vaccine, is sort of seen as second best. So I think messaging, good risk communication, and sort of evidence communication, but also strategic allocation of that vaccine to areas that can use the different vaccines appropriately will also be important.
I'm going to follow up on some of the questioning that Ms. Bonamici asked. And I'm a physician by training, come out of academics, and have done clinical trials. And I'm extremely worried about how we're talking about the efficacy of the vaccines. And I even hear it in the discussion here today, because in truth, you have to design the clinical trial for a common event, which is catching the disease. But there are other outcomes that we're certainly trying to prevent with this vaccine: serious illness, hospitalization, and death. And we talk about the Moderna and Pfizer as being more efficacious than Johnson & Johnson. That may be accurate in prevention of disease, catching COVID, but each of these vaccines are super effective in preventing serious illness, super effective in preventing hospitalization, and super effective at preventing death. And that, is the truth for AstraZeneca as well. That's the truth for Novavax on the data that we can see. And I'm extremely concerned that if we don't start with the positive message of, it's remarkable that we have potentially 5 super effective vaccines that are going to prevent you from getting seriously ill, that absolutely are keeping people out of the hospital, and as far as I can tell, nobody's died who's received any of these vaccines. And I see our best spokespeople from the administration on television, on cable news all the time, and we fall into this message. And the risk that we're going to run is someone's going to say, well, I heard someone say Johnson & Johnson's not as effective, so I'm going to wait a while until I can get the Pfizer vaccine or the Moderna vaccine. And maybe, Dr. Bottenheim, this is kind of your area of expertise, and I've seen you quoted in some articles, and I am extremely worried that we're setting ourselves up in a way that is going to slow down vaccinations. And again, those 3 other variables, serious illness, hospitalization, and death, all of these vaccines are incredibly effective. Would you give us, as members of Congress and others, again, because we fall into this trap. So what's the best way to message these vaccines?
I think there are a couple strategies we can draw on. One is analogy, right? So no one asks what kind of vaccine they get when they go for their flu shot, right? It's not even an issue. You may not even know who makes your flu vaccine. And so we need to transition our vaccine promotion programs to be more like that. You're getting a COVID vaccine. I think we also need to, and this is unsettled science, but we need to think about how to, as you said, really hone in on the adverse events, the severe events that are not happening because of these vaccines. And this is always a challenge for health promotion, right? We're trying to get people to do stuff so that something else doesn't happen. That's really hard. And if the thing that's not happening is even more rare and probabilistic, that's additionally challenging. So I think we need to pull in our best, social marketing, advertising people to help with these frames and these messages that make most salient for people as they're making a decision, but any vaccine is a good vaccine decision here.
Right. And so starting with the positive, right? It's starting with that all of these vaccines are super effective at, preventing serious illness, keeping us out of the hospital, and certainly, preventing death. And if you can get a vaccine, get that vaccine, whichever one of those vaccines that are available.
The best vaccine is the one you can get tomorrow.
I do worry, though, that there's that potential where folks might say, well, why are you using a less effective vaccine in some of these disadvantaged communities, and you're using and again, I don't think those aren't equivalent.
And you're right to worry about that, because that is going to happen. So I think with J&J, we can promote, it's like the convenient vaccine, like one and done. On this one, isn't that great? But yeah, the more we can take that choice away from people and not fall into the I'm going to wait for Pfizer, the better off we'll be.
to Dr. Bottenheim, your comments earlier, and I mean this in a very constructive manner, so please don't take this critically, but I think it's important when we're in an effort to try to get everyone to get vaccinated to the max extent possible, that we don't necessarily push to ask people to not ask questions. I think this is different than a normal flu vaccination. It's got much more publicity. The average American is much more aware. They're much more informed about what's going on. So I think when we say we need to try to remove cognitive load from people's decision-making process or discourage them from having choices, I understand what you're saying, but we have to be eyes wide open that when we use language like that, some demographics will actually become either more paranoid about the vaccine or less trustful of the government. We've talked about the Hispanic community with the use of warp speed, trusting the process less because of just the language. So I completely understand what you're saying, and I agree with everything at an academic and science level. I think we rather than discouraging people from asking questions, we should make the answers to those questions more readily available. And in the end state, I completely agree with you. They're all great products, and you're going to be saving your life with any of these vaccinations.
We've talked a lot about increasing confidence in minority communities, which is obviously critically important. We've started to see some success in Northeast Ohio in the Hispanic community with a program called Cover or COVID, which is more of a national, international program. The short and long of it is it's not just about translating things into Spanish, right? For our community, what we found is it's the translation, but it's also having the cultural awareness to know that, you know, we have to do more than just translate to make sure that what we're translating hits the community in a way that they can receive it. And so that I just draw that to everybody's attention. I know everyone's working on this in different ways, but we have seen some success in the Cleveland area, and I just submit that to everyone for consideration.
If I could follow up for a moment on that, it's going to be so important to gather and collate those success stories and make them easily shareable across different populations. So again, we can learn fast what's working.
Dr. Bottenheim, I think it's safe to assume that we may see more variants in the coming months. What does the emergence of these variants tell us about the international approach to vaccinations?
Well, I mean, I think I'd go back to the, none of us is protected until we're all protected. I think it's a messaging challenge and a behavior change challenge for folks in the US, because of course we're trying to think, how can we get our population vaccinated as quickly as possible? We also need to motivate people for the US to be a player globally in providing vaccines to other countries in order to do things that we like to do as Americans. Like, we like to travel, we like to have people from other countries come travel here. And that will be impacted if the rest of the world can't vaccinate. I look every evening on some of the amazing trackers that show how we're doing as doses given per 100 people or per 100 million people compared to the rest of the world. And it's agonizing. I mean, we're doing great. We have a ways to go in the US, and much of the world hasn't seen a single dose yet. That's tough. That's tough to swallow.
Dr. Bottenheim, do you believe that state and local public health departments have the information they need right now to engage with their communities and increase vaccine uptake?
They have the information. They do not have sufficient resources. So we're here in Philadelphia. We're our own CDC vaccine jurisdiction, right? One of the 64 jurisdictions. We have a fantastic Department of Public Health. Huge shout out to PDPH. But there's a lot to do right now. We need to set up vaccine providers in different kinds of clinics. We need to, put messages on buses, as I said earlier, and we need to engage with, community networks, community health workers to do all that outreach to folks who don't have, aren't on the internet all day. That takes money. And if we're going to really rely on our local and state health departments to do vaccine rollout, which is appropriate, that's why we have jurisdictions, they need resources.
And how can Congress best assist state and local public health departments in their efforts to provide up-to-date information aimed at curbing COVID-19 vaccine hesitancy?
I think again, I'll go back to the money. In addition to those resources, what I mentioned earlier with making sure we have sort of clearinghouses and compilations of best practices and what's working in different areas. I think also we need really good dashboards, especially if we want to, do the sort of double punch on the equity and the efficient rollout. Every jurisdiction should be able to pull up a dashboard that shows, how we're doing, how many doses are out, how many doses are in jurisdiction, how are we doing on race, ethnicity, and age, and social vulnerability index. And those are intensive, data resources. Support to get those stood up and keep them active and dynamic is also really crucial.
Professor Bottenheim, thank you for your work in our great Commonwealth of Pennsylvania. Wanted to ask you a little bit about the vaccine uptake so far in Pittsburgh and Philadelphia, sort of two opposite ends of our state. But the common thing that we have seen in both places, and many people have commented on this, is a higher rate of very serious infection, particularly in the African American and Hispanic communities, but a lower rate of vaccine uptake. The numbers I have here are that in Philadelphia, only 12% of people vaccinated in the first weeks of the rollout were African American, while the city's population is 44% African American, and a much higher share were going to hospitals. In Pittsburgh, we saw the exact same thing. So what we are looking at is how to make the specific investments that will fix this problem. Obviously, beliefs related to vaccine are a big issue. But if we just kind of set that to the side, would you agree that the massive investments we're about to make in community health centers, federally qualified health centers, and the hiring of 100,000 people directly through local public health departments, do you think that those will help us make an impact on these disparities?
I think it will work. And I think the other ingredient that's needed when the implementation of those programs is that we are smart about what barriers different people are facing. So when you give us the statistics for Philly that say 11% of the people who've been vaccinated are Black, but our city is 40% Black, there's a lot of heterogeneity. There's a lot of variation underlying that. Some of those people don't want to be vaccinated, and the kinds of programs and outreach and support we need to get them to make a good decision for them look one way. Some of those people, never got the email because they don't have email, or have been confused by the portals, or aren't easily able to hop on a bus and get to the vaccine site. So back to my earlier testimony about making it as easy and hassle-free as possible, that's a different kind of intervention. So just like we want to accurately diagnose whether someone has COVID, we also want to accurately diagnose where people are in that journey, let's call it, to getting vaccinated, and use those incredible federal dollars that support to target and tailor interventions to help people along that journey. One specific example.
I think what I was trying to suggest is that by spending the money in this way directly to local public health departments and community health centers, we're going for a geographic distribution of manpower, or person power, rather than saying, using all the money on FEMA setting up mass vaccination sites in every city that you have to have transport to. So I just kind of wanted to get confirmation that you think that goes along with what you're calling it, making it easier, which could then help have kind of a snowball effect for people in those communities to get it.
It does. And, FEMA might work great in some jurisdictions, and the stadium might work great in others. So, figuring out what assets we have locally to leverage is really important, because it's not one solution. We know that pharmacies have worked differently in different areas.
Great. Go Quakers, and thank you for participating, everybody. Madam Chairwoman, I yield back.
Dr. Bottenheim, I was fascinated by your testimony on vaccine hesitancy and distrust of government. And I completely agree with you that this is less a discussion about virology and more of a discussion about psychology when we're talking about overcoming vaccine hesitancy. However, I think that something Dr. Huang said about distrust of government really resonated also, which is that people don't want to feel like their government is forcing them to get the vaccine. And I think we have to be very cautious about that, because in a way we've said we're not going to make it mandatory, but in other ways we're kind of telling them that they are. If we're telling them that their children have to be vaccinated to return to school, if we're telling them that they have to be vaccinated to get on a commercial aircraft, what are your thoughts? How do we tread this path towards steering people in the right direction to get vaccines, but not alarming them by requiring them to get it and enhancing this distrust of government?
Yeah, this is a question we're getting a lot, sort of where do mandates potentially fit in with this vaccine? And most of my research pre-COVID was on the childhood schedule and whether you had to vaccinate your kid to go to school, to have the kid go to school. So very, very relevant. Fortunately, just regulatorily, we're still in emergency use authorization and we don't actually have to contemplate mandates quite yet. We're very unlikely to mandate a vaccine that's under an EUA. But it's gonna be a fine line. I really think about this as not trying to get to 100% or 80% of people vaccinating, but trying to make sure that everyone's been reached with information and support to make the decision that's best for them. That's really different from how I think about sort of parents vaccinating their kids. I want you to get your kid to the measles shot, sort of, the end of story. But we are obviously going to have situations. We mandate flu vaccine for healthcare workers in some settings in some states. There are going to be airlines that are going to say, just as you have to have your yellow fever vaccination to travel to certain areas, you have to have your COVID vaccination. What schools and colleges do about students coming back, especially, I think it's going to be more relevant for colleges with congregate living, maybe than for elementary schools. But those, luckily we have sort of templates for those conversations. But for the general public right now, there should not be even the feeling of mandate or must. Maybe there can be some language around should or would be great, or we're very gung-ho about this and we hope you are too. But we can absolutely steer clear of mandate language for now.
Okay, well, thank you.
Dr. or Allison Bottenheim, in your exchange with Dr. Barra, you said the best vaccine is the one you can get tomorrow. And so people are concerned about we've got two different kinds of vaccines, right? We have Moderna and Pfizer. How close are we on Johnson & Johnson? Do you know?
I think their EUA hearing is next week. But we also know that there will not be the amount of supply for that vaccine that we have for Pfizer and Moderna. So it's not like we'll suddenly have another third of supply. There will be limited. Right. We've been told in Philly we will have much more limited supply of J&J.
And this may be a question for you and Dr. Neusel, I guess it is. That do we have a comparative analysis? In other words, how successful is the Pfizer? How successful is the Moderna? What are the numbers there that have been vaccinated? What are the numbers of adverse reactions? Do we have that kind of information?
I shouldn't speak to post-marketing surveillance. It's not my area of expertise, and unfortunately, I think Dr. Neusel had to drop off. But in general, the trials continue, and that we still, through our different monitoring and surveillance systems, and the local folks here who are vaccinating locally can attest to this, gather all sorts of adverse event data, and we're starting to accumulate the longer term safety and efficacy data. That's ongoing and will be for months.
Okay, in her exchange with Mr. Tonko, I think she said herd immunity was around 75 to 80%. Do we know where? I guess that's the ideal herd immunity, quote unquote. So where are we now? Do we know that?
Well, we know the number of doses that have been delivered, and we know the number of people who've had 1 dose versus 2 doses. The mystery number is how many people have actually had COVID and how much do they contribute to herd immunity, meaning how long are they protected? I've seen ranges from about 20 to 40%, it's a big range, of residents in the US have some form of protection now, either through prior disease or through vaccination.
Okay, and you talked about the need for local jurisdictions to be able, to track that progress.
Yes.
Are we finding different jurisdictions, Texas or others, do things better and are tracking these better? Is there a model jurisdiction out there that you would recommend?
I should let Dr. Wong and Mr. Reed weigh in on what they're doing. North Carolina has a great dashboard. Many states have dashboards that are not being run by the government. They're stood up by talented citizens who want to be able to see this. But I think we need to sort of rapidly share best practices and how to collect and analyze and display that information to guide decisions.
Perfect timing, Dr. Bottenheim, because I'm from North Carolina. I don't know if you saw me kind of doing my little happy dance about our dashboard. And I just this week had a roundtable with community health providers, with our HHS, with NIH, and with our all of the local hospitals here. And I'd like you to tell the folks why our dashboard is good and would be a model. We didn't have a fast start. We had some difficulties, but I believe we're catching up. And if you could talk a little bit about the dashboard, and then I have a couple of other questions that came out of that roundtable.
Sure. And I should clarify, the dashboard I had in mind when I said that is one of these that was set up by an academic team, Dr. Paul Delamater at UNC. And I actually don't know how well it complements the state dashboard. But what's important to see for me is, for example, in Philadelphia, it is less helpful for me to just see how many doses have been given to different sociodemographic groups. I want to see rates. So, we talked earlier about, 11% of the doses in Philadelphia have gone to African Americans, but 40% of the population is African American. Show me that in rates, so I can very quickly see only 3%, of this group versus 15% of that group. And then the granularity is really important, especially for jurisdictions that are going to be using something like the Social Vulnerability Index that was mentioned earlier to do equity-based allocation. You need to see that at a pretty fine level of detail. Zip code's okay, census tract actually better. So right now, for example, that you can sometimes see maps that show sort of zip code of doses given, but by provider, not by patient. So, we need to use those data. And then it needs to be dynamic. Lots of us are checking these dashboards every night, and, numbers that are really bumpy because we don't report over the weekend, or, 3 to 7 day lags are hard. So real-time data, granular data, and data that are presented as rates, so that we can do comparisons, are what's most useful.
And this is Phil Wong. Could I add one thing in there? Just, it really highlights the need for investment in our data systems. It came out during our testing data and all of that, but then also, as we've been going out with the vaccinations, the mass vaccination centers, getting the reporting into our state MTRAC systems. We were, during the first weeks, having to do it all paper-based, and so it really limited the timeliness, the amount of data we could get back. Now we've transitioned to a paperless system using QR codes, but all of these, it shows how much there's been neglect of some of these basic data systems and infrastructure for public health that really are so key.
Thank you so much. One final question. In that same roundtable, we heard, and somewhat sadly, that there was vaccine hesitancy among healthcare workers for them to get the vaccine. And that's concerning, obviously, because they are in contact with patients, but it's also concerning because they're supposed to be our ambassadors to good healthcare. Could you tell us what you've been learning about convincing all of our healthcare workers to get the vaccine?
So, this was a really important area of focus because that was the first group that we vaccinated. So we had data quickly on sort of which groups were saying yes and were saying no. I will say the same race ethnicity based disparities that we see in the general population, we got a signal about that in healthcare workers, also by occupational group, which is of course correlated in many cases with race ethnic groups as well. And one area where we're particularly seeing gaps is in the long-term care or nursing home workforce. So I think there's nothing sort of different about how we're going to approach this. Some of this, again, is going to be these longer term, more intensive face-to-face conversations, making sure people have repeated opportunities. It wasn't just like there was this one chance to get vaccinated and you missed it. And figuring out who are the sort of persuasive peers or the validators that can help bring people along.
And are there any incentives to getting vaccinated? How does that work? And I know that there have been some folks in North Carolina who have looked at that as well.
It's hard to do justice to in 20 seconds. Incentives are very controversial. Does a $20 gift card work? Does a $1,500 big investment that looks like relief money work? My personal opinion as a researcher is that this is not a great place to use incentives. And one reason I'll say about that is that one thing incentives can do is signal to someone that the behavior you're incentivizing is difficult or risky or hard or unpleasant for some reason. And I think that's not the message we want to give with this vaccine. But I know there are lots of interesting programs and experiments with trying incentives.
One last question. Is it possible for a vaccine to cause autism?
The great preponderance of data, and there's a lot of it and a lot of studies, it's hard to prove a negative, but there has not been any credible research, sustained, replicated, that gives any suggestion that there's a relationship between vaccines and autism. It's an incredibly sticky worry. It's very hard to unstick people from that worry, I will say behaviorally, but no science to support it.
Before I excuse the witnesses, let me say one more time how much we appreciate you being here and how helpful your information has been. Our witness is now excused and our hearing is adjourned. Thanks to all of you.